All right, I think we're going to go ahead and get started. Good evening and welcome to the UW Health Liver Transplant Patient Education Session on Donor Options. Thank you for joining us. We're looking forward to sharing valuable information about liver transplant and living liver donation with you this evening. We're very happy to partner with the American Liver Foundation to offer this patient education session. We have over 50 attendees registered for this session. That includes a number of attendees here in Madison, as well as attendees via our webinar from 12 states across the country, and actually we have a few international patients who are joining us too, so pretty exciting to be able to share our information with so many. We encourage you to ask any questions you have, and for those of you who are on the webinar, you can type a question into the Q&A box on the navigation panel and direct your questions to the host only, and that will ensure that the question gets to us, and we'll be answering all questions at the end of the presentation. Our speakers for this evening include a multidisciplinary panel from the UW Health Liver Transplant Program. We have with us Dr. Louis, who is the Surgical Director of Liver Transplantation, as well as Dr. John Rice, who's the Section Chief of Hepatology and Director of the Liver and Pancreas Center. Beth Spaeth is one of our liver transplant clinical nurse transplant coordinators. Maureen Garvey is one of our transplant social workers who works with liver transplant patients. And in addition to our transplant team, we're very lucky to have two special guests with us tonight. Alfredo Lopez and Susan Kleppen are here. Alfredo received a liver transplant at UW, and Susan was his living liver donor. And they're here this evening to share their transplant and donation experience with us. And now I will go ahead and turn it over to Dr. Rice, who will be beginning our presentation.
Okay, so thank you all for coming and those on the internet for tuning in. I'm going to talk a little bit today about just a little bit about the whole process of liver transplant, some of which you may be familiar with, some of which you may not know. And it kind of segues into the discussion about donation and how one gets a liver transplant. So the outline of my talk is just going to be defining what cirrhosis of the liver is, which is the most common reason by far that people get a transplant, what the complications are, why do we do liver transplant, what the evaluation process consists of, and then what the wait list means, and then different donation or donor types. So what is cirrhosis? It's basically abundant fibrosis or scar tissue. So if you've had stitches, surgery, anything like that, it leaves a scar. Scarring can happen on the outside, scarring can happen on the inside. And when the liver gets scarred to the point it has a lumpy, bumpy appearance, which it looks like on the right here in the picture, we call that cirrhosis of the liver. Typically, cirrhosis develops over many, many years of long-standing liver injury. So something's been going on typically for years. And that process of developing cirrhosis is frequently not symptomatic. So people are not aware there's anything going on with the liver, that there's a problem with the liver, but the liver is being damaged and being scarred. Eventually, it takes on a lumpy, bumpy appearance, which we call cirrhosis, and that's really when we start to see complications develop. So it's kind of a busy picture here, but the complications of cirrhosis, for the most part, fall into three major categories, one of which is the development of liver failure, one of which is the development of portal hypertension, which is high blood pressure in the big vein that brings blood into the liver. And the picture on the right, what that's supposed to represent, is just where the liver gets its blood supply from. As you can see, it drains the esophagus, stomach, pancreas, the intestines, spleen. So there's a lot of volume going into the liver every minute. And high pressure in that vein system causes a lot of complications. And then cirrhosis is the principal risk factor for liver cancer or hepatocellular carcinoma. So liver failure, so the liver is a vital organ. What I mean by that is it's not something that we can remove and you can live without. So it's not like a gallbladder or tonsils or the appendix. You have to have a liver, and it doesn't have a replacement machine, so there's no dialysis for the liver. It has many processes that it does. It helps big time with the digestion and processing nutrients from the diet. But it's also an important line of defense from toxins that are generated in the digestive process, and then protecting against infections. Many of you probably know your intestines are lined with bacteria, and that's a normal thing, and it's essential for life. But those bacteria need to stay out of the rest of your system. When we do blood work for the liver disease, we can assess liver function looking at the blood work. And the three things we generally measure, or the two things most oftentimes measure, I should say, are bilirubin and INR. Bilirubin is a substance that your body makes when it's turning over old blood. So as it breaks down to old blood, it makes bilirubin, and your liver's job is to get rid of that bilirubin. So if it doesn't get rid of it, it can build up in your system, and you can turn jaundiced or yellowed, have a yellowing of the eyes and skin, the urine turns dark. That can be a sign that the liver is not working properly. And then the blood thickness is controlled in part by the liver. So the liver makes clotting factors, so if you cut yourself, substances the liver makes and are circulating helps bind, basically enclose that wound. And so we can measure blood thickness through a test called the INR. Those are used to calculate something called the MELD score, which is an important score, and many of you have probably heard of the MELD score already, which we'll talk a little bit more about. So the MELD score is a numerical score that runs from 6 or -6 if you're a kid to 40. And it's a numerical score derived from the bilirubin, which again is a marker of liver function, the INR, which is also a marker of liver function most of the time, creatinine, which is a marker of kidney function, and then the serum sodium concentration, how much sodium is the concentration of sodium in the blood. The MELD score has been around for quite a long time now. It's excellent for predicting risk of dying from liver disease. So the higher the MELD score, the risk of dying goes up. So its scores of really 18 or less, the risk is fairly low over the next 3 to 12 months. But as you start to march higher and higher towards 40, that risk goes up fairly dramatically. Portal hypertension is high pressure in the portal vein. The pressure of the portal vein should be about 5 millimeters of mercury, so relatively low pressure. But as that scarring of the liver develops, the blood can't get through easily anymore and basically acts like a dam to the flow of blood. And so the blood can't get through easily, and so it starts to back up behind the liver. And as a result of that, you really get 3 major complications with some other stuff we can talk about. You can get varicose veins or varices on the inside. So any vein that plugs into that system can become big and distended. And varices, the risk is bleeding, okay? And that risk of bleeding, if it's going to bleed, it's usually the esophagus. So if you've been scoped before to look for varices, the reason that your doctors are doing that is they're trying to see are big varicose veins forming on the inside, and if there are there, do we think they're at risk of bleeding or not? If we do think they're at risk of bleeding, we need to act before they bleed because it can be pretty dramatic if they do. Fluid in the tummy called ascites, so is also from this portal hypertension, and then confusion or encephalopathy. The varices or varicose veins, again, the real risk is bleeding. In the pictures that I'm showing you there, the picture on the top is what a normal esophagus looks like if you're looking straight down the esophagus with the camera. In the bottom right picture is the esophagus with varices, which you can see look like big varicose veins, squiggly blue lines. Again, if they're going to bleed, it's usually the esophagus, and the bigger they are, the more likely they are to bleed. So the EGD, or upper scope, that people have done is used to assess the size and then to consider treatment if we think they're at risk of bleeding. The fluid in the abdomen is called ascites, and as the pressure rises, fluid begins to leak out of the liver. And it fills the abdominal cavity, or it can fill the lung cavity as well. I don't mention that here, but it can do both. It's uncomfortable and it can get infected. It's also nutritionally depleting to have that fluid removed, so it can be a big problem. The treatment we usually recommend to start with is a low sodium diet. Sodium causes swelling, so the more sodium you eat, the more quickly the fluid's going to accumulate. For some people, water pills, which basically force the kidneys to make more urine, can basically cause you to drain out that fluid. But for some people, the combination of a low-salt diet or low-sodium diet and water pills don't work. And for them, needle drainage, which we call a paracentesis, is the only potential treatment for the ascites. The third big complication is called confusion, or what's called encephalopathy in medicine. And basically, it's unprocessed toxins from that the liver's not cleaning up. And it's getting around the liver and going into the rest of the circulation and then causing confusion. Ammonia is probably the most famous toxin responsible for it. It's really not the only thing that does. It does lead to confusion, which can go all the way from just mildly disoriented, some stuff as simple as even just being a little bit more forgetful, all the way to being actually in a full-blown coma. To try to prevent complications of encephalopathy, some people are treated with lactulose, which is a sweet syrup. It's basically a non-absorbable sugar, which binds ammonia in the stool and causes it to come out in the bowels. For anybody on lactulose, it's universally detested because of its flavor and then also because of the effect it has in the bowels. So nobody likes it. In my career, I've had 3 people say they actually liked it, so out of a lot of people. And then there are certain antibiotics that can be used, rifaximin being the most common one used for encephalopathy as well. Then I mentioned liver cancer. So hepatocellular carcinoma is another word for, is basically liver cancer is the medical term for it. Cirrhosis is considered a precancerous condition. It is the #1 risk factor for liver cancer. But that being said, most people with cirrhosis will not get liver cancer. All patients with cirrhosis should have regular scans to look for early tumors. Liver cancer won't cause symptoms until it's fairly large and advanced, meaning it's big or invading somewhere it shouldn't invade or spread somewhere. So we look to try to catch it when it's early because it is typically a slow-growing, slow-spreading tumor under most circumstances with the potential to cure it, but we got to catch it when it's early. There are a number of other complications that I haven't covered here. Hepatopulmonary syndrome and portal pulmonary hypertension are changes that happen with the lungs in cirrhosis, and they're relatively uncommon, but they can happen. Muscle cramping, so particularly people who are retaining fluid, and muscle cramping can be a really big pain, for lack of a better word. Muscle loss, so especially people who are retaining fluid in their tummy or if it's around their lung and it's getting drained all the time, the loss of muscle mass can be quite dramatic. Many people have a hard time sleeping, and that actually has been shown even in animals. If you give an animal, a mammal, cirrhosis, they'll reverse their sleep-wake cycle. Fatigue and then cold intolerance or feeling cold all the time are also complications that are common to liver disease. I didn't mention itching. Itching is another very common one, particularly in people who have like PBC or PSC. They frequently can have major problems with itching, and that's related to bilirubin not being processed. So with that being said, we talk about the complications of cirrhosis, talk about liver transplantation. It's a big surgery, 4 to 8 hours or more, and I suppose Lou would probably say oftentimes more than 8. The liver with cirrhosis is removed. It's the whole liver, okay? There's no cirrhosis left. The whole liver is removed and replaced with a healthy donor liver. Then you have to hook up all the plumbing. There's veins going into the liver. There's veins coming out of the liver. There's an artery going into the liver, and there's a bile duct carrying bile out of the liver. All of those have to be sewn together to allow for blood flow and then for bile flow as well. Who benefits from a liver transplant? So when you see somebody, who would benefit from a liver transplant? So the MELD score of 15 has been the kind of golden rule for mortality benefit. What I mean by that is that for people with a MELD score greater than 15, a liver transplant provides a mortality benefit, meaning those who get transplanted are more likely to be alive a year later. For those less than a 15, that's actually not the case. But so that's where the MELD score of 15 comes into play. And they also have to have limited prospects for recovery. So some people, maybe if they've had alcohol recently, or if maybe they have hepatitis C, for example, and we want to try to treat it, if you can remove the underlying insult, sometimes the liver can fairly dramatically improve. Other people who might benefit from a liver transplant are those with uncontrolled complications. So for people who are getting ascites drained out of their abdomen on a regular basis, regardless of MELD score, they clearly would benefit from a transplant. For people who have kidney problems as a result of the cirrhosis, which we call hepatorenal syndrome or liver kidney syndrome, they would also benefit from it. Terrible confusion despite treatment. So if you're on lactulose and you're still bouncing in and out of the hospital or it's really affecting your life, you might benefit from a transplant regardless of MELD score. Other complications as well, itching, cramping, things like that, all potential things that a liver transplant might be a benefit for. And then some patients with liver tumors, hepatocellular carcinoma is actually the most common reason that we do liver transplant anymore. And for many patients with hepatocellular carcinoma, liver transplant will be curative of the cancer. And then certain other tumors, there are more rare tumors that occasionally we do transplants, but that's a very infrequent occurrence. So when you have a liver transplant evaluation, what does that mean? Well, it's a team approach. So you'll see a transplant surgeon like Lou, a hepatologist like myself, a coordinator like Beth, a social worker like Maureen, substance abuse counselors if needed, a dietitian, and then other specialists as we deem fit.
Yeah.
We're trying to claim who's on the A team here. Lou, you're going to get a mohawk if you want to. All right. Broken. So other specialists as needed. So if we think we need the assistance of one of our cardiologists, for example, we'll involve them as well. And really what we're trying to answer is 4 questions. The first one is this problem bad enough to warrant a liver transplant? So there are people who have cirrhosis, and some people may have cirrhosis who don't have any complications whatsoever, or the complications they have are relatively easy to control with pills. For those people, they may not benefit from a liver transplant at the present time. So we want to make sure that we're providing a service that this person actually needs. Then they need to go through a medical evaluation. And what that means is that if Dr. Fernandez takes you to the operating room and starts an operation, do we have a reasonable expectation that you're going to survive the operation? Okay, because that's a obviously very important thing. And then we don't want to have any other problems that might limit life expectancy otherwise. So some people, like say if they had lung cancer that was not considered likely curable, doing a liver transplant would just put somebody through a very difficult and painful operation with a limited prospect of long-term survival. So we really want people to get the transplant, recover, and have a nice, long, happy life afterwards. So we got to make sure that all of our medical testing indicates that we can do that successfully. And then so we call psychosocial evaluation, which means can the patient take care of a liver transplant? A liver transplant is not part of the original packaging. Okay, so it's not the original liver. It has different genetics than the original liver. And the immune system, which is the white blood cells and antibodies that your body uses to fight infections like colds and flus and funguses and things like that, invaders from the world, well, it isn't sophisticated enough to know that a transplant's there to help. It just knows this isn't part of the original package and it needs to go. So we have to give medicines to lower the immune system to prevent rejection. And what rejection is the body's immune system fighting the new liver and causing problems. And then ideally not so much that you get sick all the time. Okay, and usually for liver transplants we can find a nice happy medium. But people really get out of it what they put into it. If they take medications religiously, most livers don't reject it. If they do, it's usually easily treatable and not a big deal. But the only way we know something's rejecting if you get blood work. So blood work, at least initially, is fairly frequent. Can you keep in contact with your coordinator? Do you come to clinic? All that sort of stuff is very important when it comes to taking care of a liver transplant. I tell everybody you get out of it what you put into it. For those who take care of it, we've had people, I still have people in my clinic transplanted from the 1980s. I wasn't doing this in the 1980s. I was in grade school. But it just goes to show you.
I was in kindergarten.
Yeah, you know, as I always tell some of our long-standing transplant recipients who get disappointed when people retire, that it's a good thing if your transplant team's retired on you. That usually means you've done really, really well. And the last one I always ask is, does somebody want to pursue this? I mean, obviously most people would say, I don't really want a liver transplant. And most people would say, like, well, if you really think this is going to save my life, I will take a liver transplant. But we want to make sure people are educated and understand what the process is, what the expectations are, and make sure they make a decision that we consider as informed as possible for their health. Once all that testing's done, you've met everybody as part of the workup and the evaluation process. You go before a selection committee, which is not just any one person, but the whole team. And all the medical tests and consultations are reviewed, and we make a decision, which is yes. If it's yes, then we go on the wait list. If it's no, we tell people why. And then they are always going to get a second opinion at a different program. And then if it's deferred, it means that we're trying to answer some questions that are a little bit murky at that time. If we need another medical test or something along those lines before we can make a good decision. For those where the answer is yes, they go to the wait list. And it's the list of approved patients waiting for transplant. People oftentimes ask, where am I on the list? Well, that's a really hard question to answer because it could change within an hour. Because people are added and people are removed. People are moving up and down the list. So where you are on Monday at 8 a.m. may not be where you are at Tuesday at 8 a.m., okay? Waiting time is not a factor. So for some organs like kidney transplants, wait time does play an important role. But with liver transplant, you can wait a day or you could, in theory, wait 10 years. Wait time does not matter. All that matters for deceased donors is MELD score and blood type. And we'll talk more about that. Why blood type matters? Well, we have to match by blood type. Okay, so O's have to get O's, A's can get A's or O's because I won't get all the details about that. But basically, you got to match with a compatible blood type. If you don't do that, it's not pretty. Okay, so you have to match by a compatible blood type. Blood type also matters because it also has an impact on how long you might wait in the liver transplant waiting list. Now, these wait times that I've got here are, Lou probably has some updated slides. It's gone down a little bit from here, so we've had some more donations, and so the MELD scores here are pretty high. They've come down some since the last time I updated these slides. But the bottom line is that nationwide MELD scores are reasonably high at transplant. And unfortunately, what that means is higher MELD scores at transplant means sicker at transplant, a tougher recovery afterwards. And I usually tell people, take your MELD score as the number of weeks it's going to take to start to really recover and feel well. And unfortunately, it also means an increased risk of dying on the transplant waiting list, which is really a difficult and awful thing to have happen. Amongst the donor types, there's two that we do. Deceased donor, which accounts for about 90% of transplants done in the United States, and then live donor. Deceased donors are the most common, as I mentioned before, and this is where the blood type and MELD score matter. It is dependent on the MELD score. If you're on the O wait list and you're at the top of the wait list, your MELD score is the highest in blood type O, and an O donor becomes available, that's when you get the call, okay? So if you're suffering quite a bit at a MELD score of 18, you're probably not going to get a phone call, even if you have a lot of symptoms, and that's the hard thing about the MELD score. It accurately predicts mortality risk on the wait list, but it does not predict suffering, and that's the hard thing. There are two types of donors for deceased donors to be aware of. There's donation after brain death, where somebody's had such a severe head injury that they are legally brain dead, won't blink their eyes, won't breathe spontaneously, they don't have to do anything automatically. And that's the highest quality deceased donor, and everyone goes on that wait list, but it's also the most competitive. Some patients get offered what's called DCD, or donation after circulatory death. And basically that's somebody's had a head injury but not legally brain dead, but the family decides they really wouldn't want to continue to live in the state that they're left with. If they expire meeting certain criteria and their heart stops, they're allowed to be an organ donor, but there is a period of time where the liver's not getting blood and can impact the long-term success of that transplant. Everyone opts yes or no to DCD. So if you go through a liver transplant evaluation, we will go over this with you in detail about the risks of a DCD and say yes or no, and people can change their minds as many times as they want. The advantage is it's a shorter wait list, so you're more likely to get transplanted sooner. The downside is there are an increased risk of complications after the transplant that can impact the success of that transplant. Live donor is relatively uncommon in the United States. It's about 10% of liver transplants done. We get matched by blood type, so that's not an option to go outside of blood type. It has to be compatible. It's a right lobe donation, usually to adult to adult. Kids and babies can get by with a left lobe or a left lateral donation, which is a smaller operation, which I think we'll look at the details about that on. The advantages are really twofold. You get the high quality transplant of the brain dead donor. Okay, so you get a high-quality liver transplant that's been getting a nice, fresh supply of blood all the way to the point it's removed for transplant, and it's not dependent on the MELD score. And that's the real advantage, is that if you have a MELD score of 17 and you're getting paracentesis once a week and not moving up the transplant waiting list, and you have a live donor, we can schedule whenever we're ready, and you just go. So that's really the advantage to live donation is it's the best of both worlds, is that you get a high-quality donor and you don't have to wait. I mentioned here a little bit about deceased donors. I won't go over this in too much detail. There's been a big push for organ sharing, just so people are aware of that, is that there are some discrepancies between regions of the country about how sick people are at the time of transplant. And so right now we're doing something called Share 35, which means that if anyone in our region, which is Minnesota, Wisconsin, and Illinois, has a MELD score of 35 or higher, any liver that becomes available in the entire region gets offered to that individual. So it used to be that in University of Wisconsin, we have our own organ procurement organization. Our donor hospitals, if there became a donor available, they would send the organ to us and we would transplant the first person on our list. The potential now is that could go to Chicago, could go to Minneapolis, could go to Mayo. So there's some more sharing. That's going to change again to something called Share 32. And 150 nautical miles, sometime in probably the next 18 months. I mentioned about the DCD liver as well. There are some increased complications to that. I mentioned again the live donor, the advantages of not being dependent on MELD score and the high quality of the transplant, which is comparable to the highest quality brain dead donor. The disadvantages is donor risk, which we'll talk some more about. And there are some increased risks of some mild complications immediately after transplant. I will talk more about live donor safety, but donor safety is the paramount importance at the our live donor program. Anyone who wants to be a live donor has to go through extensive screening and counseling, really covering their overall physical and psychological health. Are they really physical enough to undergo a voluntary operation? Are they psychologically healthy enough to understand what they're getting themselves into? Do they have any pre-existing liver problems? Some liver diseases do run in families, and we want to make sure we're transplanting somebody with a quality liver and not removing a portion of the liver from somebody who really might need the whole thing. Is the liver anatomy suitable for donation? What the financial and recovery implications and expectations are, and then the risk of the operation is covered in detail. And then we're committed to lifelong care for any donation-related complication for all of our live donors. And with that, oops, I think it's your turn.
Yes. Well, thank you for being here this afternoon. And for those that are listening from remote areas, you're missing a beautiful spring afternoon. Wisconsinites get incredibly happy for, the coming of the spring because we've been battling for very long, a long winter. But we're going to try to make this simple. Some basic concepts, how do we do the process, who qualifies, how to go about it, and the idea is to try to maximize the opportunity and have access to transplant before it's too late, okay? The topic that we're going to be discussing is who can benefit from a live donor liver transplantation, who can be a liver donor, what is the involvement, how is the evaluation process to become a living donor, and what is the recovery like. And at any given time, Susan, if you want to interrupt me, being a living legend, obviously, please feel free. And of course, we will actually go over some of the common questions that are being asked with their respective answers. It is interesting, in the United States, last year, there were over 10,000 deceased donors in the whole United States. That's a record, never been as many as they were before. And you wonder why, and probably it's a contribution of many things that we don't want to hear. The epidemics of opioid intoxication, many of those organs, tainted or not, with hepatitis C, and why not? But the truth of the matter is that for the very first time, we almost reached 17,000 liver transplants done, which was amazing. But unfortunately, there is not enough liver transplants to save everybody on the waiting list. And there is about 1,500 people in the United States every year that we have to remove from the transplant waiting list because they are too sick to be transplanted. And another 15,000 that unfortunately dying, battling, as a consequence of the cirrhosis of the liver. So what we would like to do, and this is something that we identified years back, is how we can actually have access to transplant to all the people that are on the waiting list, whether they have a high MEL score or they have a low MEL score. And the live donor liver transplantation is a beautiful solution for that because it allowed us to transplant someone with a good quality liver. And more important, which is actually something that we underestimate, or at least myself underestimate, is the power to allow a family member to be part of the recovery of the loved one, which is a very powerful and very beautiful human, things to be able to do. The basic principles is that if there were enough deceased donors, we wouldn't be doing living donors because the truth of the matter is that those individuals do not need that surgery. And they get, associated with a surgery that has some risks. And the truth of the matter is that, we're here to minimize the risk for both donors and recipients. In some areas of the world, unfortunately, this concept of brain death doesn't exist. The concept of donation after cardiac death doesn't exist. And the only thing that is available is living donors. Places like India, places like Korea, places like Turkey, are doing somewhere between 1,100 liver transplants were done in Turkey last year. There is a center in Korea, for instance, that they do about 550 live donors themselves in only one institution. But if you ask the number of deceased donors that they do, it's a handful of them. And that has to do with cultural as well as regulatory issues. The truth is that living donation saves to life, the recipient and the next patient on the deceased donor transplant waiting list. Because at the moment that you are giving, you're taking that happy recipient, hopefully, away from the suffering of being on the transplant waiting list. What are the advantages? The advantage is you don't have to wait, like John mentioned before. The surgeries are always scheduled at a convenient time, both for the donors, the recipients. Hardly anyone think about the surgeons, trust me. A liver from a living donor typically lasts a lot longer than a deceased donor, and allowed us or enabled us to transplant before recipients get too sick, and goes back to some of the concepts that that John mentioned about the MELD score sometimes does not reflect the suffering that the patients have while they're waiting for an organ. And again, allow the donor to participate in the recovery of the recipient in a very meaningful way. And I will let Susan talk about that later. Sorry that I put you on the spot. So to me, I have been asking myself many, many times, if I actually need a liver transplantation, how am I going to go about this? How will I ask a loved one, to donate a portion of their livers? If that will be a too selfish request, to give to my family members. And the truth is that over time, I have figured out that recipients feel very uncomfortable to us. And recipients sometimes are concerned for donor complications, and correctly so. And recipients are also concerned about the donor recovery. So it's a kind of like many surgeons in the hospital will tell me, wow, Lou, you are the only person here in this hospital that is willing to actually have a 200% victory or a 200% mortality. I say, what are you talking about? I say, you're taking two patients at the same time, the same day, for two very complicated operations with the hope that the person that is healthy can donate a liver and save the one that is sick. And the truth is that there is a risk for both. But sometimes it's what you need to do to be able to mitigate the suffering on the transplant waiting list. And then there is some questions about concerns about the cost. Who will pay for what? And the truth of the matter is that we have an incredible team at the University of Wisconsin that will take care of those. The majority of the cost is incurred by the insurance company of the recipients. Believe it or not, it is much more economical, okay, for any of you guys that have liver failure to be transplanted than coming back and forth to the hospital with complications related to the cirrhosis of the liver, not even to mention the suffering. So once you actually have enough experience of doing this, this is actually a very beautiful way, to do it. The truth is that the MELD score correlates with the chances of dying on the transplant waiting list. The higher is the MELD score, the greater is the chance of dying. However, there is a lot of symptoms that MELD score are not represented in the MELD score. I mean, the symptoms of ascites, confusion, repetitive episode of infection, and not only that, but the burden that causes, to family members, fluid accumulation in the chest, fatigue, and more important, poor quality life. So, in general, in the United States, we think about life donation strictly to people that have a MELD score less than 25. The truth of the matter is that we have done people that are in the what we call acute fulminant liver failure, and we have done live donors in order to save their life. Do we actually like that modality in a very strenuous situation? I mean, think about fulminant is those patients that have 7 days to live unless that they get transplanted. It is actually a tour de force. We have done it in the past successfully, but we try to prepare, or we prefer rather, to transplant people when they are early in their MEL score, because the chances for them to recover are a lot greater with a living donor. What is the benefits of live donor liver transplantation? Actually, this is data that was compiled among few centers that do live donor liver transplantation in the country. It represents about 750 people that were put on the transplant waiting list. And the question that was asked is, who is better off? Someone who need a liver transplantation, regardless of the MEL score, and have a living donor and get transplanted with a living donor, versus someone that have a living donor. Unfortunately, that living donor did not qualify for donation. So in theory, we're comparing apples to apples, right? The same quality of recipients. And then, unfortunately, that donor was eliminated from being from proceed to donation. And then the question that I ask is, what happened 5 years out? And the truth is that 50% or 56% of the people, are at a significant greater advantage if they receive a living donor in comparison to the deceased donor. And this is actually reflected in this slide, in which it was categorized in blue for those that receive a living donor liver transplant, and those that did not receive a live donor liver transplant in red. Remember, those that are represented in red are not necessarily people that receive a transplant, because if you are on the waiting list, few things can happen to you. You can still be waiting after 5 years for a liver transplant. I hope that never ever happened. But unfortunately, we have seen that in the past, in many, many occasions, that patients actually are battling with symptoms related to cirrhosis for many years, and unfortunately, the MEL score does not represent the acuity of their symptoms. So you can be transplanted and you did phenomenally well. You can be transplanted and you didn't do well and you die, or you never got transplanted and you die on the waiting list. So those are represented in the green, sorry, in the red. What is the green? In the red bar. I'm daltonic now. In the blue bar are those that receive a living donor, whether they did well or they didn't do well. And as you can tell, the probability of surviving at 5 years is much greater in any of these groups. And then again, they divided between 6 and 10, 11 and 14 MEL score, 15 and 19, and over 20. And I think that has to do with access of care. Okay, if you ask me personally, do I think that a good quality deceased donor is the same as a living donor? I would say yes. Do you think it's better? I would say what is better is that you have the opportunity to be transplanted. Because in reality, when you have cirrhosis of the liver, there is not a clock back. That cirrhosis is going to continue progressing. If you are lucky, it will stay steady. Okay, but it will never improve. That liver will not get soft and beautiful out of the blue. We haven't actually, medicine hasn't reached that level yet to understand how to reprogram the liver, to be able to beautify the liver again, to make it soft and smooth with great function. So going back to the question, if I get a liver failure, how will I go about this, right? I asked myself the following question. Will I be able to ask someone that I love to give me the liver? Probably yes. Will I ask their opinion about what will happen if I am not in their life, which I think is something important, okay? And maybe they will say, it doesn't matter if you die. Maybe they will say, no, we can never, ever allow that to happen. Or I could get a champion, someone who will be representative of my interest and will be someone who is emotionally close to me, but is looking at perhaps my best interest and trying to identify suitable living donors. And I think that is actually one great way to go about it. If you feel that you don't have the courage to move forward and ask yourself for that gift. I always tell people, that is very powerful to tell your own stories. You need to tell people, how do you feel? What is the process of being sick? What is the process of being having cirrhosis of the liver, being told that you need a liver transplant and nobody's calling you, and you wait for the phone and the phone doesn't ring. So what is the feeling of that? And sometimes when you tell those stories, you will be surprised. But someone might have a call that want to actually do good and will be willing to actually serve as a donor, and that person might be your donor, and it's an unexpected donor. The other thing is that share your stories. You know, there is social media, right? Facebook, Twitter, Instagram, and God knows what is coming next, right? The truth is that this is very powerful. Telling people your suffering, telling people what you feel, okay, can take you a long way. And we have plenty of stories, not only on the liver side, but also on the kidney transplant side, in which just telling someone anonymous have made a big difference, okay? How do we think about this process? We think, let's say that all of a sudden there is 25 people that call in behalf of a potential recipient. How do we go about, you know, who do we give priority? Normally we think about family first. Family are the people that we think that should be screened first just because of the close proximity. Essentially siblings, spouses, right? Adult children, you know, parents. Interesting enough, if you look at actually distribution of donors worldwide, females are normally 60%, 40% male donors. Okay, speak about the beautiful nature of females and probably their relation, you know, with their family members. Their community, that's the next step, you know, friends, coworkers, you know, classmates. And then again, last is extended network, you know, social media and so forth. In the past, our transplant program was not envisioning the possibility of what we call anonymous, non-directed donation. In other words, someone that is willing to donate a liver but doesn't have a designated recipient. However, we have accumulated over the years enough experience that we feel that we have matured enough to be able to do that. So if anyone, you know, is in need of a liver transplantation and we get a call from an anonymous moving forward, we're going to be able to entertain that as a possibility. Normally, what we search for a living donor is someone that is in good health, normally between the ages of 18 to 16 years of age, that have no diabetes, no fat infiltrating the liver, and the truth is that none of us know, right, whether our liver is fatty or not. That need to be tested, but we will test that. Have a blood compatibility with the recipient, have an altruistic motivation that is not being triggered by, you know, secondary gains. And again, the average is between 20 and 60 years of age. The type of living donations can be directed. You know exactly who are you donating to. And non-directed, again, someone who essentially becomes as an altruistic donor that would like to donate to a stranger. Other terms that are being used to the non-director are anonymous donors, unspecified, community donors, and the Good Samaritans. The truth is that, to me, anyone that step forward, regardless of the link, meet all those, you know, descriptors. You might wonder, if someone actually all of a sudden out of the blue contact our program and want to be a donor, how do we actually figure out who will be the recipient for that, having an extended transplant waiting list? And essentially, we will, the physicians and nurses will actually get together and try to follow standardized processes and avoid discriminating anyone for sex, or race or, credo or a religion belief. And what we would like to do is to try to match characteristics of the donor and the recipient in order to maximize that gift, and that gift goes for a long time. The first steps are very, very simple steps. If you have a potential donor, ask them to call our program, okay? Likely Beth, right, will be returning your call or answering your phone call directly. And then she will actually go for a very simple screening process. And the idea behind is to try to avoid that any of your loved ones that want to go through this process waste their time. If we feel that there is medical reasons why that individual will not fit our program as a potential donor, we would like to avoid them right away so they don't waste their time. The other thing that we do is that we have an independent donor advocate team that will actually look at overall the health of that individual as well as the interest of that individual from proceeding as a donor. We divide our evaluations in 2 days. The first day is a day that they normally meet with a transplant surgeon, whether it's myself, and I tend to do somewhere between 70 to 80% of the evaluations, but I have 3 other faculties that also are very well trained on live donor liver transplantation, very knowledgeable, who will be actually able to interview donors as well. And the reason why I perhaps don't do 100% of them is because sometimes I also evaluate recipients, and we do not want to be conflict of interest. The moment that we are evaluating a donor, okay, that donor will actually exclusively get an independent team from the recipient team in order to be able to manage that patient without being biased and looking at that patient's interest. I understand that that patient wants to donate, but we want to make sure that the interest of the recipient team is separated from the donor team, and the process is very transparent. The other thing that we do is Beth normally sit down with 95% of the potential living donors. She only doesn't sit down in those potential living donors that are intending to donate to pediatrics, because that's her area of expertise as well. She does a lot of coordination for the pediatric liver transplant program. Social worker, right? And then we proceed with imaging. And the imagings are very, very important, okay? Because the imaging will allow us to determine the percentage of liver that that person can safely donate and the percentage of liver that is going to be residual. And we calculate somewhere between 60 to 70% that we can remove without compromising the health of the donor. Why we can do that? Because the liver is like a starfish. You cut an arm, the arm grows again. It's exactly the same. And it's incredible the speed that the liver regenerates. Okay, so about 80% of that liver will grow back in the first month after donation. Same growth happens, but at a much reduced pace in the recipient, and probably have to do with some immunological factors, and also because we give them anti-rejection medications, and some of those anti-rejection medications slow down the regeneration capacity. Maureen will meet with any of those patients, and her work, I think, is as important or more important than any of the advice that you will get the very first day. And the reason is because she wants to make sure that you're doing this for the right reasons, that the infrastructure around home is appropriate, okay? We want to make sure that your insurance disability is covered, we want to make sure that you are prepared for unexpected, outcomes. We want to make sure that your family is protected. Because let's say in case of spouses, right, all the kids, right, may actually, if an adverse outcome were to happen to both parents, right, the kids will be unprotected. And we want to make sure that we embrace all that and we prepare donors and recipients appropriately. The second day is a psychological evaluation. There is a physician who has nothing to do with John and I or the transplant program, who specifically will look at that donor and their health, and we call it the third party. He has or she has nothing to do with the liver transplant program. She's a physician and internist, and she will actually look at vaccinations, look at your health in general, look at bad habits that you might have that want to eliminate before donation. And then, more important, we'll go over about the usual questionnaire. Are you voluntarily doing this? What is the purpose? What are you trying to accomplish in the process of donation? So we eliminate the coercion, aspect of it. And then we proceed to set up the day. That is the day in which, truly, we all transplant surgeons are very excited because we are allowing the opportunity for someone to be transplanted with a beautiful organ. And actually, it's an operation in which, even though we are in a training program, faculty get involved 100%, okay, because there is no room for errors here. And I know it's not that we take less important deceased donors. It's not the case. But the level of difficulty of this procedure is a lot greater. And as a result of that, we want to make sure that we provide our best. What to expect in terms of admission in the hospital? Any donor will be admitted in the hospital on average between 5 to 7 days. Susan, how many days were you in the hospital?
8.
8. The recovery time, 6 to 8 weeks. When were you
back at work at 8 weeks?
When were you working?
At 8 weeks.
8 weeks.
Mm-hmm.
Okay. More than 50% of the living donors return back to work in 4 weeks. Amazing patient satisfaction. Again, to be able to help someone that they love. The cost, we talk about it, donor testing, surgery, routine visits are all covered by the recipient's insurance. For the traveling, some insurance will provide additional supplement for the potential donor to travel. We can actually also apply ahead of time to a National Living Organ Assistance Center. It's a process. We will help you how to do that, and for the most part, pay completely for the donor traveling costs. In the state of Wisconsin, we're very proud of this. For any donor, they can deduct up to $10,000 of the state income taxes for loss of wages related to organ donation. We were the first state that approved this, and of course, thank goodness, other states follow. And currently, I believe we are 25 states that are able to recover the loss of wages through the tax income return. The follow-up required for any living donor, we normally bring them about 2-3 weeks after. I believe that you came week 2, right? And then we follow them 6 months, a year, and 2 years after. For those that are outside, we can actually arrange a visit that will be convenient for them. Not necessarily all the visits have to happen at our institution, but I encourage that at least the anniversary and the second year they are here. There is no special diet. There is no special medication. There is no restrictions about the activities or exercise, that donors are going to be restricted later on. we do recommend a healthy living after donation. The truth is that we've been doing live donor liver transplantation in the United States since 1989. And the truth is that a very, short track record, if you want to call it that way. So we still don't understand much about very long-term consequences. So far, there is no articles published about adverse outcomes of donation on the donor. What are the potential complications? I always talk about potential complications from left to right. And the reason is the more liver you take, more risk you have, or more risk the donor has. If you actually are donating the left lateral segment for an infant, okay, the risk of mortality is 1 in 1,000. If you take the left lobe because the donor is intending to donate to an infant or a small petite, adult, the risk is about 1 in 500. However, if you donate the right lobe, which is the majority of the need for an adult, we're talking about a mortality rate of 1 in 250. Now, where those numbers come from? Those numbers are coming really from liver resections that are done in patients that have cancer. The casuistic is very small to be able to provide conclusions about the risk of mortality in living donors, although there has been 4 live donors that have died in the United States since 1989. And I will go over about that in a minute. Complications of this procedure depends who's doing it and depends on who you read as well. I would say it goes between 18 to 40% complication rate. Some of them can be minor complications. We grade them between 1 to 5. Most of the complications that we have in our program are 1 and 2, minor complications. A urinary tract infection, an IV that infiltrated and got infected, a little bit of cellulitis or infection in the wound that requires a little bit of antibiotic and nothing else. More complicated, adverse outcomes are, for instance, a pulmonary embolism, a clot that originates in the legs and goes to the lungs. That have occurred in 1 case out of 35 cases that so far we have done at our institution. Bile leak is about 7%. It tends to increase the incidence depending on how many bile ducts we end at the end of the procedure, how many of those we need to connect. Normally are 1 or 2. Hernias, that means a defect in the abdominal wall that likely will need to be repaired, about 16% of the people, and then others. Again, in the United States, there have been 4 deaths of right lobe, 1 death of left lobectomy. In the entire world, after 14,000 donations, there have been 34 people that died. If you look at mathematically, it doesn't correspond to the numbers that I talk about, but I prefer to exaggerate in terms of potential complications so people digest those numbers and agree that, yes, we're not God here. We're trying to help people, and there is potential complications after a big operation. The right lobe, again, constitute about 60 to 70% of the liver, and is what we normally use for adult liver transplantation. The left lobe, again, 30 to 40%. How do we decide what to take? We actually look at the MEL score, and we look at the size of the donor and the size of the recipient. And we have a computerized system. It's funny, we always, talk with our radiologist and say, okay, now today you're going to be a surgeon, cut the liver. So they have a program that they can cut the liver and estimate what residual volume the donor will keep and what are they able to donate safely. So again, I do some funny mathematical exercise here. We talk about, misconceptions. We talk about the right lobe being half of the liver and the left lobe being the other half. That's not true. The right lobe is about 60–70% of the liver. The rest is the left lobe. The mystery of regeneration is what we talk about. That liver that is cut, for instance, in the case of Susan, I'm sorry that I used you as an example, Susan. Susan donated close to 70% of her liver. And her liver was functioning completely normal, like nothing ever happened to her about 3 weeks after. And we never had the need to actually do radiographic evaluation of the liver. But normally, again, take my word for it, 80% of that liver will go back to normal size in 1 month, and about complete normal restoration of the size of the liver in about 3 months. The interesting thing is that the major vessels do not grow back. So here's a question like, wow, my donation was so successful. Can I donate to someone else now? No, you cannot donate to someone else. Because,
but I would.
because thank you. Because the vessels do not regenerate. It's only the parenchyma of the liver. And the shape of the liver doesn't go back to its normal configuration. It grows in a kind of disorganized way, but functionally goes back to normality, again, in 3 to 4 weeks. So in contrast to the story of Cinderella, a large donor can fit, for the most part, a small recipient. However, in many occasions, we see a small donor does not fit a large recipient. However, do not get discouraged. If the only person that you have is a small donor, we will be willing to evaluate that donor. Because many occasions we have surprises. You know how people talk about, well, that person has to have a big heart because it's an incredibly kind and a beautiful individual. Well, sometimes people have a big livers that do not correspond to the stature of that individual. And obviously, happy to evaluate that as a possibility. So the question of what is the right to fit? And then in centers that have significant more experience, like in Korea, they actually are even embarking in the process of 2 donors for 1 recipient when one ideal donor have not sufficient liver mass to donate. So they take a portion of the left lobe in one donor, a portion of the right lobe in another donor, and they put it on the same recipient. That has not been done in the United States yet. Okay? So in conclusions, I want to just wrap up and allow you guys to enjoy their story, and more important, to go and try to answer your questions. There is a significant need for living donation. The truth, again, is that the deceased donor pool is not sufficient. And the suffering that many of the people have because of their low MEL score, the MEL score, unfortunately, not in all patients reflect the acuity of their disease. Living donor recipients do better than deceased donor recipients, and it's not because it's a better quality organ, it's just because they have access to transplant faster. And most living donors recover fully without complications. And again, I'm happy to entertain any questions. I will stay at the end. If you do not want to voice, your question and you want to be private, I'm happy to answer those as well. But let us actually evaluate any of your potential donors. And more important, tell people, share your story, because After that story, you might find a solution of your problem. Thank you.
We're up.
Who wants to speak first?
So our story started in October of 2016. Alfredo and I had been together for many years before that. We knew he had fatty liver disease. We knew that it was evolving into cirrhosis. His liver function tests were elevated, but he had no real symptoms. But in late October, one night, he got sick at home and vomited blood. And we went into the emergency room, and sure enough, he had the complication that Dr. Rice talked about. He had varices. And in the emergency room that night, they did an ultrasound, and they also saw two growths, which were identified later as hepatocellular carcinoma. So he had cancer that had also grown, related to the cirrhosis, unrelated to cirrhosis, I guess, who knows. The very first time we went to see the hepatologist after he had the scope and the banding done on the varices, the subject of liver transplant came up, and that was pretty frightening. I had gone with Alfredo to be his support person, and all of a sudden we're talking about liver transplant, and I'm like, really? So we progressed into the next year, into 2017, and Alfredo had a procedure where they did radio frequency ablation of his liver tumors, where they essentially stick a needle in and they heat it up and burn it up, right? Mm-hmm. Good description.
Yeah, we call it a supper.
A supper. And so that took care of those two spots, but Alfredo embarked on the liver transplant evaluation after that was done. And that was the first time I'd ever heard of living donor. I didn't know there was such a thing. And interestingly, I'm in healthcare, and I had no idea that living donor transplants for liver were done. So when I found out that Alfredo and I had the same blood type, I was all over this. And I was like, well, I'm going to get evaluated. And we had many heated discussions at our house because he didn't want anything to do with that. He didn't want me to do it. He didn't want me to be evaluated. He didn't want to ask anybody else. He thought this was his problem and he should deal with it, right?
Yeah, just wait.
Yep. So his MELD score was really low. At the initial diagnosis, I think it was, or at the initial evaluation, I think it was 11. It wasn't high, and it was going to be a long, long wait. And the risks for waiting, as they described, just get thicker, and then, of course, he could have had growth of cancer. So I think it was probably March, so like 2 months almost had gone past, and I finally said to him, I don't care what you say, I can't sit here and know that I have the same blood type as you and not be evaluated. I'm no spring chicken. I was 56 at the time. I'm 57 now. And so I was at the upper range of a potential donor. And so I called Beth and I said I wanted to be evaluated. And she did a little screening and she said, okay, we'll see you. So I went in for the 2 days, and it was a long 2 days of poking. I think it was 16 tubes of blood I counted. The MRIs there were two that were done, one right after the other, one in one machine, and then they moved you to a different part of the hospital with a more complicated machine, and you laid there for a long time, hours, being scanned. But, I mean, nothing hurt. And after we were done with that, I took a little vacation, and I came back, and then we did the third day after everything was looked at, all the testing was looked at, and it was still determined that I was in the running to be his donor. We did the third and final day. And we were told that, yes, I would be suitable. But there was still one problem. This guy. And it took yet another visit with another surgeon. I don't even remember who he saw, but another surgeon who sat down with him and said, you're being given a gift, and you better take it. So.
Well, they found more growth.
He was due for a MRI or CAT scan. I don't remember which they did. And there were some what they called hot spots that were seen, not identifiable as tumor yet because they were too small, but that was pretty worrisome that there was something else there now. And he had to be convinced.
Yeah, that pretty much what tipped the balance for me to decide, okay. But the biggest concern was on how it was going to turn out for Susan. I could deal with my own complications, but not with hers. So that was difficult, but she was more than willing, and she was very determined. Very.
I think we had the same interest, right? We were both more worried about the other person. I was more worried about him and what was going to happen with him and what my life would be like without him in it. And he had the same concern for me. So finally he decided it was a go. We actually scheduled it, and we got canceled at the last minute for a chest x-ray abnormality that Alfredo had at in the last chest x-ray that was done. And so we got put on hold for a little while. But on August 23rd, so this week it's 7 months for us, on August 23rd of 2017, we had our surgeries. And I went in first, and I was not scared. You'll laugh at this. I was not scared because these people at UW Health answered every question I had. I knew exactly what to expect. I didn't have any more questions. And that morning, I'm in the first day surgery area waiting to go back, and Dr. Fernandez came back, and he's like, "Oh, you ready to go? Or you still want to do this?" And I said, "Yes." And then he started talking about complications, and then I got scared. But luckily, somebody came in and gave me some drug that made me really not scared. And off I went. But I think that's the other thing that I really appreciated about Dr. Fernandez and the team is that they said, if you change your mind at any point, we'll just say you're not a suitable donor. And you don't have to feel guilty about it. You don't have to have an excuse. You just say, sorry, it's not going to happen. It's not suitable. And I didn't change my mind. I got a little nervous right there at the end, but I didn't change my mind. I didn't really have any complications, I'm lucky to say. I think Dr. Fernandez was just keeping me around in the hospital because he was still there. I don't know. But
the truth is, and I never told you this, but, you know,
oh, great. Here
while you were in the hospital during that week, you know, it took me an extra 20 minutes to get to my office because it happens to be that Susan knows a lot of people. So everybody was like, how is Susan doing? So I had to just, you know, do the sign out.
Make the round.
Make the little, you know, information about the progress that Susan was making that day. So, but it was quite interesting. She was actually a very popular patient in the hospital.
We've tried to keep our sense of humor through all this. That's been hard, and to try to keep a positive outlook. It's also been hard at times. We made it a contest in the hospital. Who was going to get better and faster out of the hospital? I can remember, I don't remember much in the ICU, in fact. Marie said she was there, and I don't even remember. But we were in the intensive care unit. I think it was the second day. And I looked up, and Alfredo was standing in the doorway with a walker. And he looked at me, and he said, "I'm winning." Because I hadn't been out of bed yet. So that was my motivation to get out of bed. And so I walked all the way around the nurse's desk to his room, and I stood in front of his door and said, "I'm beating you." So that was kind of our competition. But I did get up home first, which actually was good. We had a lot of things to think about because my plan in the beginning was I was going to take care of him, but now I was going to be a patient too. So we had to have a plan of where we were going to go afterwards, who's going to take care of us, how are we going to get the simple things done, who's going to cook, who's going to clean, who's going to mow the lawn, all of those things, but the team makes sure that you've thought through all those things. And then we also thought through things like we were each other's healthcare power of attorney, so now we have to modify that. We made sure we had our affairs in order so that if something happened, everything was going to be okay. What do you have to add?
I just said yes to everything. Yes, dear, to be precise. No, I'm very lucky that I have someone that thinks deeply, far ahead, and considers everything. So my memory and my thinking wasn't functioning as prior. I would forget things, or I would not think further than where I was and the concerns I had. But Susan was able to push me in the right direction, take me in the right direction, and I'm very lucky for that. Yeah.
Alfredo has a son, I have a son, and he didn't want to ask somebody younger or his son to donate. He felt really strongly about that, but I pushed a little bit. And if I wasn't suitable, I guarantee you I would have pushed him to find somebody else. But I was happy to do it. It turned out well for us.
Yeah.
I mean, I went back to work at 8 weeks, but honestly, I probably could have gone back sooner than that. But Alfredo was, you know, still sick, and he had some complications. He's still, well, after yesterday, he's pretty close, right?
That's right.
But that gave me the opportunity to just keep an eye on things at home and on him. By that time, I was up and about and doing what I needed to do. And I didn't really have any complications or didn't have, I felt like I was ready to go back to work sooner than 8 weeks, but I took it off. And honestly, when I went back to work at 8 weeks, I went back for a couple weeks at half days. That was good, because I did get tired out after being there.
So, Susan, any advice that you would give to those potential recipients about how to go if you collecting, your memories of the process? What would you do differently? What do you advise that you think that worked really well? And what was the minute that you were able to convince Alfredo to accept that beautiful gift?
Well, I would say if somebody's willing to give you the gift, don't turn it down outright. I mean, this team is very careful, and they have your best interest at heart as a donor. And Dr. Fernandez alluded to the fact that you have your whole separate team. So if I went to an appointment with Alfredo, I saw an entirely different team of people taking care of him than were worried about me. And in fact, Dr. Fernandez was my surgeon, and now has been following up with Alfredo, so he gets both of us. But he was mine first.
You won again.
So don't outright think that living donor isn't for you. I would try to be open to it, and don't be afraid to ask family members. I never heard that part about finding a champion. I think that's terrific. But I can tell you as somebody who was able to do this, I can't imagine not doing it. And I would do it again if somebody asked me. Now, I just heard tonight I can't. No, I think we've had that discussion. Alfredo's trying to get part of my pancreas now, which apparently is out of the question.
I tried.
But it truly is something that was so meaningful for me, and it's strengthened our relationship. Of course, we're a couple, but I can't imagine that it wouldn't strengthen any relationship. And if you're lucky enough to get an anonymous donor, well, that's something that should ultimately be considered. I mean, what a gift that is to give your liver to somebody that you don't even know. Honestly, I don't know. I don't have anything else. Do you have anything to add about what made you change your mind, or how you feel about it now, or do you wish you wouldn't have waited so long to be convinced?
Well, I was resigned to just to stay in the waiting list because I didn't want Susan to go and risk her health. But after I was told that there was more growth coming up, then I started thinking seriously. And then that night we had another conversation, and as I said before, Susan was very determined, and I thought, okay, being in the waiting list is no longer a alternative. So
for him, he would have waited a long time. I'm not sure that he would have made it through that. I don't know. You guys could speak that, but it would have been a long, long time before he would have gotten to the top of that list.
Well, I think that because we love each other, we think about the other person first, and that we had two competing desires. I want her to be healthy, not to expose herself to any risk, and at the same time, I want to be there for her. And it's hard to, at the beginning, to accept that what you need might put a loved one in a bad situation later on. But now looking back, my concern was, and it always is, in the right place with your feelings. And in reality, it went well. Susan recovered quickly, and she's healthy, and I'm still around. And I'm very grateful that she didn't listen to me. Yeah. And
I never heard you say that either, that if you're a donor, you essentially save two people. I've never heard that. And it makes you feel good too. I think the other thing that we did was we had very open and honest discussions with our family so that they knew what we were considering, and I talked at great lengths with my son because Alfredo isn't his natural father, and he actually said to me, well, if you can't do it, I'll get tested. So I feel like we had a fallback. Same blood type too.
I never heard that.
Yeah.
That's great.
We just tried to think about the pros and cons of all of it, and that was all covered here tonight. The pros, the fact that Alfredo wasn't very sick when we got to that point, to the point of transplant, was a big advantage, I felt like. And honestly, the evaluation was so thorough that in the midst of all this, I went into my own doctor for my regular physical, and she looked at me and she said, I don't know what you expect me to do because they have just proven that you're very healthy and there's nothing else to be done. And just gave me a pep talk and sent me on my way. But I honestly have a whole window into my own health now because I know where I was in August I was in a good place with my health, and I still am.
Wonderful. Thank you for sharing that.
Mm-hmm.
We have a question out there.
Was the cancer contained in the liver?
Yeah.
And could we ask Alfredo's age?
what was it?
What's your age?
At this moment, 60.
Okay.
He was 60 at the time of transplant.
Okay.
Yeah.
Thanks.
He's got a birthday approaching.
Yeah.
You said that the recipient's insurance pays the majority of the cost of their insurance. Does that apply to VA as well? I'm in the VA program that
So the VA program is soon to come. We have actually done the request of paperwork there is only 2 programs that are interested on providing this service to veterans. We're one of them, the other one is Pittsburgh. None of us, okay, can do that yet. So it's coming up, and I believe that probably by October of this year, we should be able to have approval from Washington. Wonderful.
By the way, I took the tax deduction this year because I had lost wages. I had some disability insurance, but of course it didn't pay my whole salary back. And so I did take the deduction.
Fantastic.
And they didn't ask me to prove. I thought maybe I'd have to take a picture of my scar or something and send it in. I do have a pretty big scar, but my bikini days were long over anyway, so it didn't really matter.
So, Beth, anything that you want to add?
I think what I would add for recipients to think about is if you don't want to think about a live donor, think about how your decline in health, your decline in function as a family member impacts not just you, but all of your loved ones. It is hard to watch your loved ones suffer and become ill. And if people want to help you, it's not just helping you, it's helping your whole family and helping you to regain your status in the family much quicker than if you allow your health to decline where you're waiting for a deceased donor.
I guess I'd also add something to that, and that is that I always try to explain to folks that when you come out of the operating room after a liver transplant, I'm talking about the recipient here, you're going to be in the same health you were the day before you had the transplant as well. So there's a period of time where you have to recover. And for some people, that recovery is not that dramatic, but for a lot of people, particularly in the deceased donor pool, it is fairly dramatic. When I say the MELD score is your number of weeks of recovery, I'm not kidding. But if you have a MELD score of 40 or 35 going into transplant, it's going to take the better part of a year to really get back to a normal level of health. For someone with a MELD score of 17, it is entirely possible to be out of the hospital within a week and back at it, and within 3 months being largely physically recovered. The sicker you are, the longer the wait, the more difficult that recovery is, the more potential for setbacks. So it's the other advantage as well, is that the optimal MELD score to transplant is really lower than what we do for deceased donors. Less than 25 would be ideal for everybody, to be perfectly honest with you. But we just, the way the organ allocation system works, we just don't have that opportunity very often.
What's the lowest living donor's MELD score have you done?
No, Lou, would you do that answer?
11?
Yeah, so I mean, if, again, it's a matter of what the, are we going to get a mortality benefit, how sick is it, what's the MELD score, but it's also what are the complications, and how is that impacting your quality of life. And so, again, there's a big difference between a MELD score of 15 and a MELD score of 30. Big difference.
I think we have a tendency to suffer alone and not to want to burden other people with what's going on in our lives. And that's why it's so important, like I said, to share your story, to let other people know, because there are people who want to help and who want to do what they can, to make your life better. It's much easier to give love than it is sometimes to receive it. And so I really encourage you to open up your heart and open up, that opportunity for people to reach out for you, whether it's a living donor or whether it's a support person that wants to help you, whatever the case may be, allowing that love.
Great comment. So for those that are out of state, or for any of you guys that have family members out of the state of Wisconsin, so you wonder, is the process going to be too complicated? And the truth of the matter is that we have extensive experience working up people from out of state. Initially, what we do is we use a small set of laboratories that allowed us to kind of assess a potential donor. But then at one point in time, we have to actually bring that patient here to Madison to finalize the evaluation. But we have been able to even synthesize those 2-3 days evaluation in just few hours in case of emergency or in case that people are coming from out of town. Again, one of the typical questions is what?
I would say a few days, not a few hours.
A few hours we can evaluate a donor. we have done it in emergency situations.
Yes.
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 So the question is then, for people that are coming from out of state, is how long are we expecting them to stay here in Wisconsin? And I would say that all depends on the outcome, okay? If I see that there is absolutely no complications, no issues, nothing to be of concern, even 3 weeks after the process of donation, they can go back. In fact, our last donor, that's what she did. She went back, she donated to her sister, and she went back to home, Oregon 3 weeks after, and she was teaching 5 weeks after. And she was actually in tremendous health. We will actually ask them again to come back for evaluation. The 6 months is a plus minus. Probably we will require them to have some laboratories so we can assess that the liver is regenerating appropriately. We would probably like to have them come back a year or two. But why not to come back to Wisconsin, right? The other question that we have is, my children have offered, but I don't feel comfortable since they have their own life and I don't want to obstruct or be imposing, right? Again, watching anyone that you care about getting sick is tough. And it's very painful in many occasions. And it does significantly affect, the family circle. I always think that if you are the recipient, you need to actually allow people to provide that opportunity to help. Whether, like Maureen was just mentioning, just to be a caregiver or being the donor. Why not? And the important question that you have to ask yourself is what will happen if you are not part of their life, and how significant will that change? And for many people, change significantly. So it worthwhile a little bit of the risk. Will donation shorten my lifespan? No. We have not seen that that is the case. We understand that the liver regenerates. What we asking people is to have healthy living. And so far, we have been able to follow people for several years, and they're doing very well. If my caregiver wants to be my donor, do we need separate care teams? Yes, they do. They do need separate teams just because, it can be very involving for both. Hopefully that's not the case. And in many occasions, we see even donors and recipients leaving the same day the hospital. But we actually encourage caregivers to be completely independent one of the other, because it's what we always talk in surgery: prepare for the worst, hope for the best. So if they are not needed, that's fine. But always is encouraged, to have someone around, at least for the first 3 weeks after the surgery. Again, we talk about regeneration of the liver. It's quite remarkable what the liver can do. There's no other organ that can do, what the liver can in terms of growing back. One of the things that is interesting is that if you donate a kidney, yes, the mortality risk is significantly lower in comparison to donating a liver. But you lose a kidney, and the other kidney doesn't compensate, but only about 15–20% of the missing kidney. We're talking about complete regeneration. Will I change my lifestyle after donating? And that's not the case. There is no special diet. There is no restrictions, okay? We encourage, again, healthy living after donation. For those that like a little bit of alcohol, we encourage them not to consume alcohol, at least for the process of regeneration of the liver. And then afterward, being vigilant about the consumption of alcohol. Will donating a liver lobe affect the ability to have children? You know, in our programs that we have done close to 35 of them, we have actually 2 donors that have actually give birth. One of them have a complication. One of them have what is called a diaphragmatic hernia after donating. So there was a little defect in the diaphragm when we were separating the liver from the diaphragm, and bowel was leaking through. So we actually have to operate and repair that gap. After that, she had 3 beautiful babies. I mean, she grew incredible. Her bellies were like immense, and she had no recurrence of the hernia, and she did incredibly well. Of course, men's fertility is not affected by the process of donation. In terms of religions, you know, all religions, regardless of the denomination, are in support of life donation. What if I decide against being a donor? Volunteering to become a donor is entirely your choice. The journey between volunteering to donate and actually donating can be difficult and emotional for anyone. Sometimes, partway through the assessment process, people decide to abandon the process of donation, and that is okay. That means that you emotionally were not ready to do it, and we will provide assistance that, you know, to mitigate that. And if we feel that it's not appropriate for your health, you know, we will abandon the process. And honestly, I ask all my donors, even the very same day, and that's a question that I asked Susan and I asked everyone in the holding area before going to surgery. What about you still want to proceed? And if the patient say no, I will have to figure out a medical reason how to bail out, because I do not want, you know, a fracture between the donor and recipient in terms of their relation. What we try is to establish a communication, and any of the people that evaluate, or we have the chance and the privilege to evaluate, what we ask them is to become part of the process, okay, and establish a partnership with us and be open. If they fear, we want to hear that. So we want to actually be part of the coping mechanism. We want to actually help them, and we equip them with the tools that they need to feel proud and encouraged to proceed. If we feel that that is not possible, again, we will also discourage the process. The easy way to contact the Living Donor Program is through the 608-263-9531. And then we have also a website with a small, very simple questionnaire that you can access. And so any potential living donor is encouraged to answer or phone. We don't judge anybody, regardless of the question that any potential donor may have. We're welcome to answer them, because even if that person is not suitable for donating, at least we're providing education to our community, which I think it has a great value. Any questions?
We do have one question from our webinar audience. An attendee from the Chicago area is wondering what the maximum donor age is, and also curious if that differs by center to center.
Yes. So I'm going to repeat on the microphone. A question from Chicago is, what is the maximal, right, the top age, to be a donor? And we normally restrict it to people, ideally, 55 years of age. We have recently extended to 60, but people between the ages of 55 to 60 have to be in an incredible health. So if an individual feels that doesn't meet those characteristics, don't get discouraged. Give us a call, and then we'll figure it out fairly quickly if you will be considered as a potential donor or not. We try to, we say 18 to 55, but we extend it to 60. And the reason for that is have to do not only as we grow older, we have more medical problems. It's not only that. It's the capacity that the liver has to regenerate, which unfortunately slow down as we age.
Are there any additional questions from our audience here in Madison?
Well, I hope that has been very informative for you. And again, we're very pleased with the sponsoring from the American Liver Foundation that have allowed us to gather here tonight and be able to disseminate something that we are so proud of sharing with our community. And we are also very encouraged. Last year we have the opportunity to transplant few people from out of state, and there is some states that don't have the opportunity to consider the possibility of live donation. And I think that, this opportunity that the American Liver Foundation is giving us is important to be able to have access to places that live donor liver transplantation is not available. So thank you for your participation, and for those that are listening to us remotely, we hope that we can see you soon here in Madison. Thank you.
I'd like to remind everyone to please complete the post-session survey. And for those on the webinar, this will be sent to you via email tomorrow. Your feedback is very important as we plan future sessions. And I also would like to make sure everyone knows that this session has been recorded and will be available on uwhealth.org/transplant on our transplant page. So if you wanted to review it after the session. Thank you, everyone.
Thank you.